so some of you may already know me from prior speaking. Our firm is also the ghost writers for, well, maybe not so much of a ghost writer, but we write the articles for National Council's Compliance Watch on issues, on legal issues and compliance issues for behavioral health. But I focus on not just compliance, but on managed care. So this first session today is on how to negotiate with managed care plans and give you some greater leverage than you think you might have. And then the second webinar will be on what to negotiate. If you just joined us, put yourself on mute if that might help decrease any background noise that we have. My law firm told me I had to have this slide, which is that even though I'm a lawyer, this is not legal advice. This is just for educational purposes, and when you want a lawyer, you should hire one. All right, let me begin with the basic assumption that I think many of us have when we encounter a managed care contract. When it's sent over to us and comes over to our desk, we immediately say, we don't have any leverage to negotiate this. I just have to take this contract as is, and I better sign it if I want to continue to receive money from this managed care company, or in the future receive money from this managed care company. My goal really is to disabuse you of that notion, that you do have more leverage than you think you have. And the managed care companies won't tell you what your leverage points are, but I assure you from having negotiated probably dozens and dozens, maybe even hundreds of different managed care contracts, that you do have leverage. And even the bigger national plans are willing to negotiate and divert or change their form contract when it's in their interest to. So the part of this webinar is to help you identify your points of leverage so the plans will change their contracts to meet your needs. I wanted to start by pointing out the importance of recognizing how dysfunctional even the marketplace is between a managed care company and you, the provider. If you put your shoes, just for a moment, in the managed care company's perspective, many times when they're going out to develop their provider networks, they see various provider types, but without distinguishing between different providers. They don't know if one of you provide better services than another, and they pay everybody typically the same amount, more or less, that renders that particular service. The other problem with this marketplace, in addition to having little differentiation, is that it's really backwards in how things should work. Take another market. Let me just give you a nice, easy hypothetical. Let's say you go out to dinner one night to a nice restaurant, and you look over the menu, and you don't just see one entree that grabs you, but 2 or 3 entrees. And the waiter comes over to take your order, and you say to him, I'll actually have 3 of these entrees, and instead of the prices written down here, I'd like them for $50, a flat fee of $50. Well, I think your waiter would probably laugh at you, because it's not you to say how much they charge for their entrees, nor is it your job or your say for how they price their entrees, whether it's going to be a buffet style, whether it's going to be a single price for 3 entrees. It's the restaurant that gets to decide, because they are the provider of the service, of dinner. In healthcare, it's exactly backwards, where the buyer of your services, the managed care entity, actually is telling you how they are going to pay you and what the methodology is, and the amount. And we have been, I think, beaten over the years to accept the fact that we don't get to come up with the methodology for how we want to be paid. Somebody else tells us how much they're going to pay us and how they're going to do that. And as a result, we have a system that really is built around the managed care companies paying you. They developed a claim system to pay providers, but it's not necessarily built around supporting good patient care or the interests of the provider rendering the service. So as a result, we really do have a dysfunctional market where the payment methodology, the financing system, is built to serve just the payer's interests and doesn't necessarily encompass the interests of the provider. The other factor or consequence of this is that we have a payment system that is largely fee-for-service, that isolates providers from each other and doesn't create incentives for value-based payment methodologies, doesn't create incentives for good care and good quality or coordination. And so there's a lot of sort of bad things that happen in our current payment system. So let me get back to the initial question about who has an advantage in the contracting between managed care entities and providers. Some of you may have heard of Malcolm Gladwell's book, David and Goliath. It's called Underdogs, Misfits, and the Art of Battling Giants. And he tells a parable, and it's the central thesis of his book, that we have the story of David and Goliath all wrong. That it was not such a great miracle that David won, that his victory was not improbable. And the reason was simply because David actually was quite strong up against Goliath. Down at that time, David had a very powerful weapon, and that stone and that sling that he had was basically as powerful as a gunshot is today. And the advantage that David had over his opponent, Goliath, was that he could stand far away from Goliath and out of harm's way in swinging the stone and against Goliath. And Goliath was expecting a adversary that was similarly armed, similarly sized for battle. And so David took him by surprise as well. And so the thesis of Malcolm Gladwell is that how things appear at first blush may not actually be true, and certain parties may have an advantage over the other. So I think if Malcolm Gladwell was looking at that same slide, he would not be surprised at this next slide where the little guy unbalanced the larger sumo wrestler, because of course the little guy does have his advantage. He's much more nimble and quick, he doesn't have a lot of weight to carry or to balance, and he could catch the big guy off balance, even though the larger sumo wrestler, of course, is stronger than him. And so the moral of the story here is that, of course, the managed care company has greater resources than you have, more staff, more money. But you too bring certain advantages and strengths to that negotiating table and certain pillars, certain points of leverage. And so the point of this webinar is to help you figure out where those leverage points are, so that when you go into a managed care contracting scenario, you don't feel constantly like just a little guy without any power, but that you do have power against the managed care company to reach a contract that helps both parties, that achieves both parties' goals. So my strategy is not very clever in name, is that you use the PEN method, which I have developed, which is simply prepare, evaluate, and negotiate. And the most important of those three factors really is the first factor in preparation, because that's when you fully realize where you have some ability to negotiate managed care contracts and where you honestly may not have certain leverage or ability to negotiate certain points. And so this is the most critical step in your managed care contracts. It doesn't mean you have to do this step every time you receive a managed care contract. If you have 4 managed care companies, you can do this prep stage once, but it should carry through and inform the rest of your negotiations. It should inform your evaluation of each contract, as well as the actual negotiations. And here, of course, is a picture of David and Goliath. So step 1, preparation. The first thing to do is to look for your strengths in negotiating the terms of that contract. And I would suggest you consider 3 factors. First, you assess your leverage, and I'll give you some information about how to do that. Second, you see where you might be able to compete based on value, the value that you bring to the table, as opposed to other similar providers in your service area. And third, if you're not pleased with the leverage you have and you're not pleased with your ability to compete on value, I'll give you some suggestions for how you might increase your leverage or your value. So the first step in assessing leverage is really regulatory. And this is where it helps to really understand the RFP that Washington State has issued for the Apple Health program, understand a little bit about your state insurance laws and about their network adequacy requirements, understand Medicaid laws or regulations that relate to managed care, to see whether the managed care company is required to include you in your network, required to cover your specific services or which services they're required to cover, and whether they're required to pay you a specific rate. Because if you come to the negotiating table and you know that the plan has to contract with you because you are deemed one of those essential providers that Washington State requires the plan to include in your network, well, then you've really gotten one of the most difficult issues right off the table. In other words, the plan can't walk away if they are required to include you in their network. Or if they're going to be submitting a bid like they're doing in Washington State and they get scored based on their network and who they have included, then it is very much in their interest to have as many types of providers that meets the expectations of the Medicaid agency or meets the expectations of the RFP, because the better, the more access they can provide, of course, to potential members for services of yours, the higher they will score. So I took a few of the provisions from the RFP for Apple Health and I just copied it right into this slide. And I would encourage you to review the RFP carefully. There are certain parts of the RFP that apply to you. For example, the network, provider network sections. And in this case, there's actually a paragraph where it requires the contractor, that's the managed care plan, to establish and maintain contracts with these essential behavioral health providers in the RFP. And on the right side of the slide, you can see who Washington State defines as essential behavioral health providers. And if you look at that list and it includes you, well, then you know you have a huge leverage point in that the plan has to maintain and establish a managed care contract with you. It doesn't necessarily mean that it suggests how much they have to pay you, but it does mean that they have to contract with you. Office-based opioid treatment providers also have similar language that relates to them in the RFP. And then you may also want to look at the provider network distance standards and look at that standard, one provider with it for every 25 miles of a patient or of a member, and recognize whether you have other competitors in your service area. There are some remote and rural counties where if you're the only provider of mental health services, well then you have a huge advantage because the plan really does have to contract with you in order to fulfill their network adequacy requirements. You may have heard in some cases where managed care companies are concerned about consolidation in the healthcare industry, where they see mergers, particularly of hospitals, merging. Well, that is because when they're faced with a sole community hospital, a single hospital in a community or a geographic area, they often have to pay that hospital more than they would pay in a region where there are competing hospitals, because now they can't play one hospital off against another. There's only one provider of service, and that provider basically maintains a monopoly in the market and can often receive the rate that they want to receive as payment. So you have to know before you go into contract negotiations whether you are the only game in town, whether the plan has to contract with you, or whether they have alternatives to contract with other agencies and providers for this same service. If you come to the conclusion, of course, that you are the only game in town, that the plan really, really, really needs you, then you might imagine that the plan is going to be more willing to modify their provisions in their contract and pay you more closely to what you want to receive. There was a national plan, I won't tell you which one, contracting with a very, very small provider agency, and we actually achieved changing the managed care contract. There were some very bad provisions in it, and they got it changed. And it wasn't because I may have been the best negotiator out there. It was simply that the plan needed the provider more than the provider needed the plan. And the provider recognized that advantage and that leverage and played it for all it's worth to get a more fair, I think, a more fair contract than they otherwise would have received. I wanted to also point out an RFP provision that allows the healthcare authority to basically terminate the contractor, the MCO, from a service area if, in their opinion, the contractor fails to maintain an adequate network of providers in any contracted service area. And that includes behavioral health providers just as well as primary care providers or hospitals or any other type of specialized provider. That means that if the plan doesn't contract with you and it leaves a gap in their network adequacy, this contract, at least in that service area, is vulnerable. And you have to recognize, of course, that millions of dollars are riding on these managed care contracts. It is very important from the managed care company's perspective to maintain their contracts and maintain them in all the counties that they are offering services in. They don't want any of these contract counties to be terminated. That will be a loss in revenue. And so if they were not to contract with you or not to contract with some providers, they would be vulnerable. And you should recognize that, because, again, it means that you have quite a lot of leverage if you're an essential provider and you're the only provider in the community. A closely related question really relates to your market power and really relates to whether there are substitutes for the services you find that you provide. I give you an example of, can you really imagine a managed care company offering a plan that includes pharmacy benefits without including one of the main three pharmacy providers, CVS or Rite Aid or Walgreens? Probably not, because each of those companies have so much market power that it would not be viable for the plan to offer pharmacy services without including at least one of those in their network as a allowable provider. The same is true really in healthcare. If you are a marquee provider because you are the chemical dependency provider or the mental health provider in your community, and there are patients, members, Medicaid patients, that would not enroll in that plan unless you were a network provider, well, then you have additional leverage there, because plans want to maximize the revenue that they receive. And part of the way they do that is to make sure that they have members and that members are choosing them. And if you are a network provider, if you're a provider and the plan needs you in their network to attract patients, members, then they will have a greater incentive to include you in their network and to make it worth your while. So it's really important to do a little bit of a sort of a market analysis. You don't have to do something that costs a lot of money or takes a lot of time, but you should certainly know who your patient population is, whether other organizations furnish those same services, and have a sense for your market power, how much of the market you command, and whether you are essentially a marquee provider that would attract patients to that plan. The third thing you want to look at is timing. Whether the MCO is establishing a new provider network that includes you for the first time, many of these plans are going to be doing exactly that. That gives you an enormous amount of leverage, because the plans are submitting bids to the states being graded right now on their provider networks. And that's why signing you up and having so many of you sign contracts or MOUs, as the case might be, that you will participate in their contract and their plan will give them more points, and the state is looking at that. In addition, you should know that after the contracts are awarded, the MCOs will probably have some kind of readiness assessment where the state evaluates whether those providers that said they would participate in the plan's network truly are participating in the plan's network. And they will be evaluating the plans whether they meet the network adequacy requirements. So at least at the outset, it's very important the plans demonstrate that they meet those network adequacy requirements. And if you doubt this, think back to when you've ever negotiated a salary for a job. Did you have more negotiating leverage in your own mind when you were initially negotiating your salary with a new employer? Or did you have more negotiating leverage after you worked there for a year and you came up for a performance review and you were asking your boss for a raise? Probably most of us would say it's when I first was negotiating a salary to join the company. And the reason is because the company has to pay you enough to have you leave your current job, or to pay you enough to come work for them. And you have more leverage in that discussion than when you're already an existing employee and you're going up for a raise. Most of us will not say to our boss, I insist on a 5% raise or I'm taking a walk. No, because we don't want to leave our job. We have a vested interest in maintaining it. So once you sign these MCO contracts, and regardless of whether it's a year's term or a 3-year term, when that term is up, don't think you will necessarily have the same leverage as you have today when you're signing the initial contract. So it is, I think, more important today to negotiate the terms of this contract so that they are fair and pay you adequately for the services you provide than to think that, when this contract term comes up in a year or two, that's when I'll try to, take a harder edge. No, at that point, you won't be dependent on that MCO for revenue, because there will be patients, of course, that you're seeing. You'll build that plan. It will be important for cash flow purposes, probably to maintain that network. At the outset today, things are a little bit different. So always be aware of time frames and whether they're making demands upon you to turn around a contract or sign a contract quickly. If they have a deadline in mind, that should be a clue that you may have additional leverage due to the timing situation. After you think about the leverage points that you have, whether they're regulatory, market-based, or timing, the next thing is to think about is whether you can compete on value, sometimes known as sort of your competitive advantage. As the marketplace, both in across the country really, but as payment systems move towards accountability and value-based payment models, providers who can actually compete against other providers based on the value that they're bringing to the MCO have an advantage. So I want to talk a little bit about how you set yourself up to succeed in this new environment. The first question to really sit down and ask yourself is to ask yourself whether you deliver greater value or potential value to the MCO. Remember, that MCO, when it's fully integrated as it will be first, since you're one of the early adopter counties, that MCO will be integrated. There's both behavioral health financing, physical health financing. It's all coming through it all goes to the MCO. So the MCO is managing the total cost of care for that population. The question for you, can you do something for the MCO to help them manage those costs better than maybe another provider? Or what value do you bring to the MCO? Are you effective at making sure your patients adhere to a drug regimen that keeps them out of expensive hospitalizations or residential facilities? Are you able to reduce ER visits or preventable hospitalizations? Can you reduce the total cost of care? And if you can, for any of these, can you actually quantify the savings? Because I can tell you what's not a good argument to make to an MCO for why you want to get paid more. If you simply say to them, I want to get paid more because you're not covering my costs, that is not going to be successful. I know we want that to be successful because from our point of view, you want to get reimbursed in a way that adequately covers your costs. But that is not an argument that sells. What sells to the MCO is being able to explain to them how paying you more or paying you in a different way will actually benefit their bottom line later on, because it will allow you to help your patients avoid hospitalizations, or it will allow your patients to get better quicker or reduce their chemical dependency so that it's not costing the MCO as much. Or maybe it even means that you'll be able to tie them into primary care for some of their chronic conditions, diabetes, hypertension, whatever it is, and that those diseases issues will get addressed and reduce their total cost of care. Whatever it is, you have to be thinking about how you provide value to the payer, because the payer, as much as you may not want to acknowledge it or put it this way, is your customer. You have two customers now. You have your patients, who of course you want to come see you, but you have another customer who's paying that patient's bills, and that's the MCO. And so you have to frame what you do in order to attract their business and to get paid in a way that supports what you do. Now, many of you may say, I don't have the data right now. I can't report on certain measures that I want to report. I can't prove my value yet to my payer. And if that's the case, then one thing you should be negotiating with the payer is access to that data, the total cost of care for that population. I have an organization not in Washington, but a client in New York State, and they have been able to quantify to a payer how much money they save that payer on an annual basis by virtue of their behavioral health services. They've looked at how much it would cost that payer if they basically fail at what they do, and the patients have all those inpatient hospitalizations and residential stays. And they've gone to a payer and say, if you contract with us and you pay us this amount, we can actually save you about $60,000 a year per patient. They have data at their fingertips. If you don't have data, then you may want to try to negotiate with the plans to share with you maybe what it costs to take care of patients that are similar to the patients that you're seeing that are taken care of by other providers, what it costs, what the total cost of care is for your patient population. In fact, you may even want to work with your Medicaid agency requiring the plans to share with you this kind of information so that you can make a business case to them about how you provide greater value. I was mentioning the integration between behavioral health and primary care. This is an important way that you can provide or demonstrate how you provide better value for your services than maybe another provider that you really do compete with, even if you don't acknowledge it yet. Many of the studies have shown that patients with, with both mental health, behavioral health issues, as well as chronic conditions, cost our program sometimes 75% more than patients that don't have mental illness. And they die sooner as well, but they're not dying and they're not costing our system more because of their behavioral health. They're usually dying sooner because of their physical health conditions that are not getting adequately dealt with, or their mental health or psychosocial issues are interfering with their adherence and taking care of their behavior of physical health issues. So this greater role in integration, these new models of integration have been shown to save money. So even if you don't have your own data, at least you can point to some of the academic studies and policy think tank studies that have shown how that leads to a savings. The other way to provide some additional value to a payer is by incurring some downside financial risk. Every time a payer pays a provider in a way that's not fee-for-service, through a case rate, through a capitated payment model, some sort of bundle payment, or through shared savings and shared losses, they're downstreaming some of their financial risk to a provider, and that's good for them. Because as an insurance company, they're really part of their business is managing costs and managing their risk. And then when you change the payment model to providers, where you're paying that provider a lumped fee every month for the patients, or you pay them a bundled payment for based on diagnosis, then that's doing a favor for the plans, because no matter how many services they may now receive from that provider, the plans limited their financial liability through that capitated payment or through that bundled payment. So I would encourage you to think about ways that you can approach plans and offer them a different payment model than simply the old fee-for-service model. In addition, shared savings programs, shared losses programs, they too offer plans a way to align their financial incentives with your financial incentives, and that too is helpful. The third thing that you have to do when you compete on value is communicating that value to the plans. Think about it when you walk down the supermarket aisle and you see the 24 different types of toothpaste brands, or even within the brands, they sometimes are marketing to different types of customers or different aspects of what they do. There's a toothpaste for those folks that have gingivitis, and then there's toothpaste for those folks who want teeth whitening, and then there's toothpaste for whoever, for sensitive gums. They're communicating marketing messages to the customer to tell them what differentiates them from other suppliers of the same product, which is toothpaste. In this new healthcare world, where you're now contracting with MCOs and you're not just being given a rate from a state Medicaid agency or given a grant from your state or from your county, you have to market to the plan and tell them what you do and how you do it and why you do it better. It really does mean doing sometimes even cold calls, reaching out to the behavioral health director at an MCO and introducing yourself, going to informal network events, community events, and speaking with them face-to-face. I have an agency, after they heard me talk, they created their own one-page marketing material, which they would actually forward to the plans and sit down and talk about with them and introduce themselves to the plan. And that's important because plans don't really know what you do. I mean, they have a vague idea of what certain providers do, but they don't always know all the services that you provide. Many payers actually give checklists nowadays so that when they're credentialing you, you can check the box so they know whether you provide ACT or some other therapy, because they don't know your scope of your services. So introducing yourself, talking about the services that you provide, the population you serve, as well as how you provide greater value, whether you can meet and manage costs, whether you can return return on investment to them, and if they can pay you in a way that, different than others, can work to your advantage. If you've heard of what I said just now and you're saying, thinking to yourself, I don't have much leverage, I'm not on that list of essential providers, or I can't actually prove my value, prove my worth to the plans, then it might be helpful to think about how you might collaborate with other providers and ways that can increase your leverage or your value. One that's going on right now are all the joint ventures essentially happening between primary care providers and behavioral health providers in forming integrated care models. Some do it by referral arrangements that are written down. Others do it by a co-location agreement. Some may do it by buying services from each other. And in some markets, actually, the primary care providers and the behavioral health providers are merging. Regardless of the model, they all illustrate a way where two providers came together and now provide something different, something that they couldn't provide alone, that has value to patients and has value to buyers, to payers. Providers can do that in so many different ways. Some do it by forming IPAs, independent practice associations, with similar providers or even sometimes different types of providers. Some call them IPAs, some call them behavioral health networks, some even call them management services organizations or MSOs. At the end of the day, whatever you call yourself is really not important, but at the end of the day, what these networks are doing is they are doing something that the individual provider either can't do on their own or can't do as well on their own. And there's a range to what these networks are providing. Some of them are just providing what I call back office services or shared support services. It might be hiring an IT person that can support all the EHR systems for a group of providers. It might be helping to share information between patients. It might be because you want somebody else to credential practitioners or to conduct the background checks. Or maybe you want a billing agent. So a group of providers get together and they form a company that can be a third-party billing agent for a group of providers. Other networks have gotten together because they want to use the network to actually sell what they're doing to another party. Some networks have come together and they form a brand and they market themselves together to a payer. Other networks facilitate managed care contracts by operating under a way that complies with the antitrust laws but allows all the members into the network to get a similar type of contract. Some networks negotiate the terms of the contract, and others actually form a network so that they can share financial risk together and not jeopardize their own agencies, but actually have the financial risk borne by this new legal entity. You know, in a world where you're seeing a change in payment models, moving away really from fee-for-service towards greater accountability through either performance incentives or bundled payments and case rates or population health payment models, it's really helpful to think about forming a network where you don't want to take these risks on your own. So if you do want to get paid, for example, on a capitated basis, but you don't want to take that risk alone and you need more patients in order to do it, then maybe being part of a larger provider network where the provider network negotiates the rate with the payer and takes on some of that risk itself, that will protect you as a legal entity. Or maybe you want a shared risk or shared savings kind of approach and you have the network take that risk. That said, as a former lawyer in the Justice Department who prosecuted provider networks that didn't follow the law, you do have to do it carefully and do it in a way that complies with the antitrust laws. Because whenever providers get together, there is a concern that they are jointly negotiating the terms of their contract in a way that's illegal. And in the same way, we wouldn't want a bunch of providers, a bunch of airlines coming together and setting fares so that there was price fixing for airfares. The same way we wouldn't want gas companies coming together and saying what the price should be. The agencies don't want providers coming together and engaging in price fixing. There is a special safety zone or an exception that allows providers to negotiate together, but they have to meet the terms of this exception under the policy statements that were issued by the Federal Trade Commission and the DOJ. And generally, in order to meet this standard, you have to be what's called financially integrated, which means that whatever services you're pricing through the network all the providers in that network need to be sharing financial risk, which can be done if that network is negotiating, for example, a capitated payment rate. For all the providers in the network, the payment rate goes to the network, and then maybe the providers just bill the network on a fee-for-service basis. Well, in that case, the network is sharing substantial financial risk because all the money that comes into that network, that PMPM money, that's all the network is going to get to pay all the providers that bill that network, and that's why those providers are sharing financial risk under that kind of arrangement. There's also an exception for clinically integrated provider networks. This is an exception that is a little bit more difficult to see because the question is, do I have enough integration in order to satisfy the agencies? Fortunately, there are many folks that have gone in front of you, and the Federal Trade Commission has a number of advisory opinions where they've guided networks on how much clinical integration they need in order to negotiate fee-for-service contracts with payers. So I just wanted to at least present those issues, not in much detail, but at least identify them for you. If you're not an integrated network, you can still form a network that has some benefits for providers that are participating. It's called a messenger model network, and this is where a network is facilitating managed care contracts but not actually negotiating them. If you have a visual kind of mind, imagine a messenger in the middle. The messenger is the network. You have A through F providers as participants in that network. The MCO offers a managed care contract to the messenger. The messenger sends out messages out to each of the providers in the network what the terms of that offer is. Each of the providers independently decide whether they accept the terms. The messenger conveys that information back to the MCO about which providers accept the payer's offer. And then all the providers have already have given signature authority to the messenger, so the messenger signs a master agreement with the MCO based on the terms that it offered. It doesn't lead to any leverage in the marketplace, but it often does save the provider's time from actually reviewing each of the contracts individually. It also means to the MCO they only have to sign one contract for a whole host of providers, which is good for them. It's more efficient, and sometimes the financial terms can be better. There's also something called a modified messenger model where the providers are surveyed ahead of time. They tell the messenger what fees they will accept. So when the payer offers the terms to the messenger, initially the messenger can immediately report back, with that payment rate, you picked up providers A, B, D, and F. If you want to pay more, then you might pick up the other two providers. And it leaves it to the MCO to offer more in order to increase the number of providers that are participating in the plan's network. So there's pluses and minuses to these non-integrated networks. There's a few efficiencies that are gained, but there's no additional negotiating leverage, and it does require some time and expense up front. Some people think it's too risky of a model because if you don't do it right, you can have some legal liability, but others find that it does take some weight off of them individually, and they like this model. I would say that if you've ever thought about a network approach, if I go back to this initial slide here with what a network can do, I would say start off slowly. I would say start off with some of the items on the left-hand side of the screen and learn what it's like to form a company and own a company together just for some of the back office services before you maybe jump into having this network negotiate or facilitate managed care contracts where it's selling your services to a third party. Because I think you usually want some experience in working together before you are dependent on your business partners for revenue. After you've adequately prepared for negotiating the terms of that contract, the next step is evaluating the terms of the contract. And some of us immediately jump to the payment terms as the sole item that you have to negotiate in a managed care contract. But really, there's a lot more to those contracts than just reimbursement terms. There's also scope of services, which defines what services the plans are going to pay you for. There's an agency that I work with right now, and unfortunately, the scope of services in their MCO agreement is wrong. It doesn't include everything they do. So they may provide some additional services to their patients, but the plan won't pay for them because it wasn't included in their scope of services. Covered services is what the plan covers under a benefit package, and of course you want to know that up front as well, because you want to make sure the plan is actually covering what you do. There's a whole range of provisions that matter in your contracts. I'm not going to cover these today. This is in the second webinar. But I wanted to point out that there's probably a couple of dozen different provisions that can affect how you receive payment, whether the plan can take back that payment from you, what the access and quality standards are, whether they can force you to participate in the commercial lines of business that they have, when they have the right to terminate you from a contract, when you have the right to terminate the payer from the contract, when they can amend it, how they can amend the contract, and appealing certain issues. So we're not going to get into that today, but there are all these provisions that do affect you as a provider. So the first step in evaluating the contract is to figure out how much time you have. If the plan gives you a deadline of 24 hours, ask them for an extension and ask them for more time. This should not be like a used car salesman where they have a price that's just good for today. If they are truly going to be your partner in rendering care to their members, then for your ability to do due diligence and for them to be a fair partner, they need to give you time to review the contract. And there's never a problem with asking for more time. Now, they may tell you that the state has a particular deadline. That's real. But sometimes, the state's deadline is not the deadline that they're telling you, because they may be budgeting some time into the contract process to negotiate with you, so they may have some flexibility. Or maybe they just have a project schedule where they want to get the contracts done by a certain point, so that you may have additional wiggle room. But don't hesitate to say, I need more time to review the contract. Particularly if you've done your analysis and you realize that you're the only provider in that service area, in that county, that they can contract with, then they need you more than you may need them. You may have 3 other managed care companies that you can contract with if this one doesn't give you adequate time to evaluate the contract. The second item to look at is to think about who's going to be reviewing your contracts. Who's going to be on your contract review team? These contracts are not like fee-for-service arrangements where you're billing the Medicaid agency. These will affect your operations, your clinical activities, and your finances. So it often helps to build a review team around those areas. Have somebody from operations, have a clinical person, and have a finance person. It could include your CEO, maybe it doesn't include your CEO. Every agency thinks about it differently. But it's not a good idea, in my view, to appoint a low-level person as your contract review team on their own. They need the support of the management team. They need the management team to weigh in on their areas of contract. It doesn't mean that your CFO has to read the all 40 pages of the contract, but they should be able to review the pages that affects payment, that affects their area, and look at and evaluate the terms of that agreement. Your clinical person should be able to evaluate the clinical terms, and your ops people should evaluate the operational terms. Third, assemble the contract. When these contracts are put together, the MCO has a challenge. They have a lot of providers to contract with, and there's many types of providers, each of which provide different services. They often also have different lines of business, and it's a challenge to make sure the right exhibits and the right exhibits and aspects of the contract are included. So you don't always get the whole thing. You may look at the contract and it refers to Exhibit A, B, and C, and you may have Exhibits A and B, and you'll need to go back to the MCO and say, by the way, we're missing an exhibit. Or maybe you provide more services than they recognize, and you need to go back to the MCO and say, you need to modify your scope of services. We actually do this and this. The other thing that's very helpful, as I mentioned earlier, is having the RFP that the plan is under. And, Washington State posts all this information right online, so you can go right to their website and pull down the RFP, and they have the sample contract that they will execute with each of the individual MCOs in Apple Health. Look at that document and identify what the plan's legal obligations are so that you have a little bit more leverage and know what the plan has to do. Fourth, think about the plan's past performance. If this is a plan that you have some experience with, or if you know its reputation, and they have a reputation for not paying claims on time, for denying a high number, for not being responsive to authorizations that you need, you can consider that and consider whether you either don't want to contract with the plan or whether you want to shore up certain provisions in that contract that relate to performance issues that you have concerns with. I've had plan providers who are concerned about how quickly a plan credentials, and so they'll zero in on the credentialing provisions of the contract. I have providers that are concerned about plans recouping dollars, and they'll zero in on those recoupment provisions. So consider the plan's ability to perform its duties, its responsibilities well. And if they don't, this might give you an indication of where you want to focus on in your negotiations. Fifth, it's okay to assess the plan's financial stability. A plan that is in the red is not going to be able to pay you. So if you have certain plans in Washington State that are offering contracts to you, but they don't have a good record of financial strength, then you should be concerned. There was one of the managed care plans, Medicaid plans here in the District of Columbia, went into bankruptcy a couple of years ago. Well, that wasn't very good for the providers who are participants in their network, because they had to continue providing services to their members, knowing full well that this plan was in bankruptcy and they were only going to get paid a couple of cents on each dollar that they were owed, because the plan just didn't have the money and the reserves would not be adequate to pay everybody. When a new plan came into town to replace them, one of our clients actually didn't contract with it because it didn't believe that this plan was financially sound yet. It didn't want to be the guinea pig as this plan got into gear and was brand new and had to hire staff. They didn't want to take the risk, so they didn't contract with that particular plan. And good thing, too, because when federal sequestration occurred a couple of years ago, that was the first plan that stopped paying providers. And because they didn't have a contract with one of the Medicaid MCOs, they did not bear that financial risk. 6, review the contract terms and understand what they mean. Most of these contracts are written in the same way and follow a very similar structure and order. So it might be a little bit intimidating the first time you look over and review a managed care contract. They can be 40, 50 pages long sometimes. Know that your investment of time will pay off and that the next time you review a contract, it will be similarly structured. They will have the same kinds of provisions that use the same and similar language. So what do the provisions mean? Which of them provide a disadvantage to you? Which are the ones that you want to fix and get and improve and change? And what are the issues that you want to negotiate? At the end of the day, this is a contract in which you're selling your services to a buyer, and you have to decide whether it reflects sound business judgment to sign the agreement. Does it adequately compensate you for the services that you provide, or is it going to harm your financial health and put you into the red? Again, I'll cover the provisions in detail in the second webinar, but it's important to know what these provisions mean and discuss them among yourselves in your group, your review team at your organization, so you can make an informed decision about what terms you want to negotiate. When we work together, do prioritize issues. Not all the issues are as important as any other. One of the worst sort of rookie mistakes you can make when you review a managed care contract for the first time is to redline the agreement. Find 20, 30 different things that are wrong in it, highlight them in the contract, and send it back to the plan. Why? Because imagine how you would feel if you would receive that contract. You are responsible now at the plan for contracting with providers, and you get that agreement back. That agreement may fall to the bottom of your stack, because that's going to take a lot of work to do. You're going to have to look at all the things they have issues with. You may now have to send it to legal department to get changes approved. That may be too much work and more work than you want to do if you are under the gun for getting the provider network completed. So if you do have issues, prioritize which are the most critical issues. I say highlight them in red. These are issues that you just cannot afford to proceed because the risks or even the financial risks are unacceptable for your agency. The second tier are things that you would like to be addressed because they create undesirable risks for you. And then the third are things that ideally would be addressed but are not essential. If you do this analysis and you find that all your concerns are in the red bucket, you've done it wrong and you need to go back and start again. Everything cannot be critical issues. You should come up with just 2 or 3 issues that are your most important issues, where it really doesn't make any sense to negotiate the other issues if you don't get these critical issues resolved in a way that works out well for you. The third step is negotiation. And I actually think negotiation has a bit of a bad rap. Most people think of negotiation as an adversarial contest between 2 parties. It doesn't need to be thought that way. I say negotiation is discussion aimed at reaching an agreement. That's all it is. Whether it's 2 people who have a dispute with each other, or whether it's Congress negotiating with the president, negotiations should be a discussion where your objective is to reach an agreement, not to bully the other party into your way, or to acceding to your demands, because that's not a partnership. And these contracts with these plans, these are going to be your partners maybe for 1 year, maybe for 3 years, maybe for 5 years. These will be your partners in rendering care to your patients. One of the very best books on negotiation is called Getting to Yes, written by a number of Harvard law professors, I think probably about 20, 30 years ago. You can pick up this book, Getting to Yes, probably for a few cents on Amazon because there's so many used copies in circulation. But one of the best stories they have, or the vignettes from that book, is about a librarian looking at 2 patrons who are arguing with each other. One patron wants the window open all the way, and the other patron wants the window closed. And she sees them, putting the window halfway and 3/4 way and 1/4 way, trying to find that middle ground that will appease both of them. And nothing is appeasing them in the middle. It doesn't seem to work for them. And so she goes over to them and she says to the first one who wants the window open, "Why do you want the window open?" And that patron says, "Because it's really stuffy in here. I need some circulation." And she says to the one that wants it closed, "Why do you want it closed?" And he says, "Because it's very drafty in here, and I'm getting cold." So she pauses for a moment, walks down to an adjacent room to where the patrons were, and opens the window in that room, allowing fresh air to go in to appease the patient who found it stuffy, but without creating a draft and coldness for the other patron. So the key, the moral in that story, as they say, is really it's not an effective contract negotiation to just bargain over what position you want, where one patron's saying, "I want it closed," and the other one says, "I want it open." What helps reach agreement is understanding each of the parties' interests and finding a way to solve the problem for both parties. And so in order to do that, it really helps to ask questions to the other and find out what is motivating them, and to appeal to them for reasons for why you need the provision changed and explaining why you need it. A good example of this is if a plan presents you a contract and it has a provision that protects the plan but doesn't protect you, ask, why can't this provision protect both of us? Or why can't this be fair to both of us? Asking questions is a way to be non-adversarial, but still to communicate and to negotiate, but to do it in really a non-threatening way. Next time you get into a dispute or an argument with somebody, try responding with questions to them and see how disarming it is to the other party. And you can often appeal to their sense of fairness or sense of even-handedness in order for them to change their mind. I remember when I was negotiating just something simple as a price. Walked into a store and I wanted something, but it was too expensive. And I turned to the clerk and I said, "Do you have any flexibility on the price?" Very non-controversial, non-adversarial way to say, basically, can you cut the price? And she said, "Yes, I do have some flexibility. I'll knock off $25. Well, that was a way for you to get a price reduction without insisting upon it. I didn't say, "I want you to knock off $25 or reduce the price." I asked if they had the ability to do it, almost empowering them. As we talk in the next session, when we talk about certain issues and certain provisions, what you'll find is I suggest making arguments that are based on asking questions why it would be the interest of the other party to change their mind on something. For example, if they have a payment schedule which is based on their own fee schedule, it may be important to ask them and appeal to them, why can't this payment schedule be based on an external benchmark, like the Medicaid fee schedule or the Medicare fee schedule, and a percentage of that? Because you certainly don't want a fee schedule that they can change at any time. You want a fee schedule that can adjust and grow and change. And so having an external benchmark is much more preferable than to the plan's own fee schedule. Asking them whether insisting upon an external benchmark usually works out to your favor. I sort of would summarize my negotiation tips for you in my Let's Be Friends Elvis way. First, educate them. Don't assume that they understand your concerns. These representatives often have a lot of providers to contract with, and they don't understand or know the individual concerns or even services offered by an individual agency. If there's a provision in this contract that would cause you a financial harm, if there's a provision in this contract that you can't possibly comply with, then explain and educate them. One of the initial mentors I had when I used to be a lobbyist for a couple of years, I didn't like it, but when I was, my mentor said, educate the staff. That is the most effective way to lobby for your interests. And the same is true in negotiations with another party. On the other side, the ancillary rule is that you need to learn from them, and you need to respond to issues with questions. If they see they can't change their payment system, or they can't pay you that way because their system has a limitation, then you have to take that into account, that maybe they can't do what you'd like them to do, at least not yet. Or maybe they need to pilot something with you, a new payment system with you, but they can't roll it out all the way yet. Help them identify ways that they could change a provision that still protects them, but it does it in a way that also protects you. You may have to be the creative one here in identifying the option that works for both parties. As I said earlier, do insist that any provision is based on some objective standard, whether it's a fee schedule that's a Medicare or Medicaid fee schedule, or it's simply appealing to fairness and even-handedness. That's an objective standard that is hard for another party to walk away from or ignore. And then lastly, stating the importance of maintaining an ongoing relationship. It sounds a little Pollyannish, but I can't tell you how important it is to be positive in these negotiations, say that you're a partner with them for the long term, and repeat that. And so that it does not appear adversarial or that you are taking advantage of them, because there are people on the other side, and I've worked with people that work for health plans, and there are many good people that work on the health plan side, and there are many good plans out there that do want to support the providers and what they do, and these are really the people that you should be appealing to. I mentioned earlier that reaching out to certain plans, maybe to pilot a new payment model or to talk to them about your concerns. I recognize that some plans will be more open than others. You probably know already what plans you are more likely to kind of make inroads with or have a greater orientation towards providers. Those are the ones you should focus your time on, because those are the ones that are most likely to be open-minded to doing things a little bit different and supporting you and hearing you. After you negotiate the best you can, you have to come back to your review group and ask yourself, is this a contract that I can sign with the way the issues have been resolved? You may not have been able to resolve all the issues you've wanted to, but maybe you resolved most of them. You're the only one that can decide from a business perspective whether you can sign that contract, whether you've resolved enough issues to sign that contract, and to weigh the risks of proceeding, even if you didn't get everything changed the way you wanted to. One thing you might think about is if you haven't been able to resolve all the issues to your liking, can you get out of the contract? Can you terminate it early in the event that things get bad and the plan, isn't allowing you, or is not quickly allowing you to credential new providers, or is not quickly responding to your authorization requests? Can you leave the network sooner than later? That might give you a little bit of a safety valve in the event that the financial or legal harm becomes too harmful. If you're still not happy, then you may have to go back to that provider network idea and think about having an agent negotiate the contract on behalf of you and on behalf of other providers together, or an individual agent negotiate the terms of that contract if you're not receiving, you're not feeling that you can do it on your own. But find some way to improve your ability to negotiate. As you think about negotiating the contracts, and before we get to the next session on provisions, you have to identify by preparing, evaluating, and negotiating. You have to prepare by identifying your strengths and weaknesses, understanding what is in that RFP that can put you in give you an advantage, whether you have regulatory leverage because you are the only game in town or the plan has to contract with you or has to pay you a certain way, whether you have market-based leverage because the plan needs you because they wouldn't be able to attract patients, and whether you can compete against other similar providers of services, if there are some that render the same services as you. After you do that analysis, think about if there's ways that you can change how you perform your services, whether there are ways to change how you align yourself or collaborate with other providers so that you can compete on value and introduce new payment models. You know, we're not used to driving the bus. Well, we're used to coming up with the payment model and offering it as a way that we want to get paid to a payer. But in the way the marketplace is shifting, we have to do that too. We can't just leave it up to the plan to decide how much they want to pay us and how they are going to pay us. We have to come up with the payment model. So you know your business. You know what you provide. I know Dale has been coaching you and helping you think about your costs and different payment models. You have to figure out a way that you can get paid in a way that supports what you do, and that takes some work and that takes some time. You might not be able to do it right now, but at least maybe you can do it in the future to put yourself in a better position to negotiate some novel arrangements. And lastly, before I take some questions, you have to recognize that you have to make the first move. The providers that have gone back, thought about how they wanted to be paid, come up with marketing materials, they've been the ones that have had to reach out to the plans and suggest that to the plans that they want to do something a little bit differently, or suggest that a new payment model. Don't wait to hear from the plans, and take the initiative yourselves, because you are now in the driver's seat as a provider in the new way of healthcare reform. All right, I threw a lot at you in the last hour. We have plenty of time for questions, so let's see if any have rolled in yet.
Thanks. This is John Freeman again. I think I've got virtually everyone unmuted. There are a couple of folks who I think called in and didn't enter their PIN, but if you under the audio section in the little control panel, there's a PIN you can enter if you would like to do that, and I've actually just sent them to both of you, so you should be in business. Other than that, I mean, we can actually have a verbal conversation with you that you want to just chat. Otherwise, you can definitely type in the questions. So I think with that, questions?
Let me ask a question to the group while we're waiting for some questions to come in. Is anybody part of a network where they have a network negotiating their managed care contracts on their behalf? I take the silence as a no. Has anybody
working with? Yeah.
Go ahead. I missed that. Say that again.
Oh, I was just going to say either that or I have somehow not unmuted them. So Charles Shelving is unmuted, so hopefully we can have a little bit of conversation here. Okay.
So Adam, this is Kirby.
Hi, Kirby. I can.
Hi. already asked you this question, but I'll ask again. We are negotiating, as you know, with 4 plans, 2 of which will get a contract with the state. So the negotiations are a bit odd because you're negotiating with some plans that aren't going to get a contract. How does that change, or does it change, kind of what you're talking about?
Well, one thing to think about is that since those plans are competing against each other, since there's 4 of them and only 2 will get chosen, and they're being graded on their provider networks, it actually is good for you. Because if there were only 2 plans and there were going to be 2 awards, then there's really no competition, and they're most likely both going to be selected. But because there's 4, you can actually play them off a bit with each other, so that if one plan offers you more favorable terms than another plan is offering you, you can say, this is not competitive in the marketplace, I have a better offer over here. And you can essentially say, I'm not going to contract with you. You don't have to say this, but you could make them think that you're not going to contract with them unless you get a provision changed, unless you get something changed to be changed. And I think many agencies are surprised when they actually start pushing back against plans and start seeing how they are flexible. That they're not accepting. They love it when providers just sign on the dotted line and don't push back at all. But providers who do push back a little bit, and because they have leverage, are able to get changes in these contracts. The other thing I would point out is, since there are essential community behavioral health providers, providers who must be offered a contract and contracted with, if let's give you a hypothetical. Let's say that you didn't sign a contract with one of the plans because you couldn't agree upon payment terms, or because you didn't have faith in them that they could do a good job, or you had some other concerns with their contract. I would imagine that once the 2 plans are awarded, if one of the ones that you did not sign a contract with were awarded a contract, I imagine that the state would tell them they have to contract with you, since you're one of the essential providers, and you would be able to get a contract later. Now, I don't know that for a fact, but the way the RFP reads, if you're one of these essential providers, then it means you're essentially guaranteed a contract. I think that would be the case both before the RFP is awarded as well as after the RFP is awarded. You are entitled to a contract either way. So you could have essentially 2 bites at the apple, one before the bid is submitted, and then once again after the awards are made, if you are one of these essential community providers.
Adam, this is Bunk Morin at Community Services Northwest. Can you hear me?
I can.
I have a question that kind of comes off the back heels of Kirby's, which is the type of contracts that they're negotiating vary. Some of the plans have offered an actual early adopter. It's not exactly a full contract, but it's the financial terms, so it's for after April 1st. Most of the other ones, including that one, came in with having providers sign Apple Health contracts, which is actually not sort of the network they are. Can't do that work, but it's for the low to moderate. And they're also some of them are having MOUs that we will negotiate in good faith, or at least that's offer. So we aren't actually negotiating our contracts that we have with them yet, with the exception of one plan that actually stated financial terms that they would agree to for year 1, or at least they did with us. So we're negotiating an Apple. They're asking us to sign an Apple Health contract, which is not a contract that really applies to most of us. Or it's probably a very small percentage of what we do, if at all. But they're using that as having us in network, and then they're having us sign MOUs that will sort of negotiate in good faith down the road, which is, I think, a little bit different than what you're describing, or maybe not, because we're not negotiating contracts that will actually be in place April 1st. We haven't seen those yet.
Mm-hmm. So yeah, I mean, I've seen some of those MOUs, and the MOUs, you're right, don't typically have all the payment terms spelled out, and it is just an MOU, which just means typically the parties are making an agreement to, in good faith, negotiate. But those MOUs also are negotiable. There are some MOUs you can advocate for language where you do have a payment amount or methodology specified in the MOU. So, for example, if you needed the MOU to reflect some method that you're currently getting paid and you believe that you're entitled to receive that method of payment when the contract awards are made, there's nothing that prohibits you from modifying and including language in the MOA that states that payment methodology, that asks for that payment methodology to be reflected in the MOU, so that when it does come back down to negotiating the terms of the actual contract amendment to include the services for what you provide, you can point back to the MOU and say, you agreed to this back at the MOU stage. And again, your leverage is greater now, so I would try to get that MOU to be as definite about the payment terms that you want in those contracts in the MOU now, because you won't have the same leverage once the contract awards are made.
Well, that's good to hear, because that's what I've been doing. So I've only, on my part, only signed one with that. How binding is that? So say a health plan comes back and goes, well, we didn't know the per member we'd be getting. Now that we see the rates, we agreed in good faith that we'd honor, the language I asked for was existing rates in the RSN and county networks for CD and mental health.
Mm-hmm.
They come back and say, well, we can't afford that. So in good faith, we tried.
I think there's not a lot of enforceability with MOAs or MOUs, whatever they're called, but they're also kind of hard to walk away from, and they make the other party look really bad if they do. One leverage point that the plans don't mention is that they hate it when providers complain to the Medicaid agency, because HCA or whoever the agency is that is in contracting with the plans, these are multi-million-dollar plans. And most of the time these contracts, and I think this is the way your RFP reads, there's an initial contract term, and then it can be renewed a certain number of years. But the state can actually not extend renewals sometimes to all the plans. They can pick and choose, and I've seen it happen with some Medicaid agencies where a plan that seemed to be a real bad apple and a dud didn't get the contract renewal, but the other plans did. So they hate it when providers complain a lot to the state about what they're doing, and I would say that if they're walking away from an MOU that they signed, and that MOU was counted in their favor, that allowed them to win the contract from the state because they were scored better, and you were to share that with the state, I don't think that puts the plan in very good light. Now, I'm not suggesting you run to the state immediately, but I think if the plan is not living up to the terms of their MOU, you should say to the plan, not the state, you should say to the plan, you're giving me no choice but to share this MOU with the state and to have them intervene. And most plans will probably say at that point, no, we'll resolve this, because they don't typically want you as a provider going to the state and getting the state involved in their disputes. So that is one way you can enforce yourself the MOU without actually going into a court of law. And most of the times you don't want to have to go to court or litigate an MOU anyways, because it's expensive. You want to find another way to get the other party to live up to their terms that they had in their agreements.
So this is Kirby again, the other part that we have, Bunk, is the early warning system that is a direct line from providers in the system in our region to the healthcare authority.
And how does that work? You're able to make a complaint, you mean, immediately?
Yes, immediately, because this is such a shift in the way we've been doing healthcare business that the healthcare authority does not want gaps or big problems to happen. So they have devised, or we're devising in the implementation team, what's called early warning system, which will include criminal justice and providers and a whole bunch of things for people that either fall through the cracks or don't have access.
Good. usually states do come up with different ways that providers can talk to them and explain to them issues that they're having with plans. Sometimes there's an ombudsman that the state appoints for the providers to contact if they're having disputes or issues with the managed care company, and they can sometimes intervene and be a successful, helpful advocate for you in resolving issues with plans. It's sort of like, I don't know if any of you have ever contacted your congressperson or your state or your senator. If you have an issue with the federal government, then your representative can make an inquiry in a federal agency, and suddenly your issue kind of moves to the top of the line. I saw that when I worked for a federal agency just by a simple congressional inquiry. The same thing is true in this context. If the ombudsman from the state makes an inquiry to the plan, sometimes your issue can kind of gravitate and move up to the top and get attention sooner.
Adam, this is Jared Sanford with Lifeline Connections.
Hi there.
Hi. So I think we're kind of in a unique situation. When I've talked to plans recently, and we talk about mental health rates, a lot of them are talking about carrying over our existing rates. And then where I have an issue is on the substance abuse rates. From my perspective, they're woefully inadequate, and they need to go up. I believe the state's doing an actuarial study that I don't believe is completed, or at least the information hasn't been made public yet. And so when I talk to these plans about those rates, they say, well, we don't have the information available. We'll pay you 100% of the Medicaid rates when those come out. But for me, it's very uncomfortable for me to agree to anything when I don't know what those numbers are going to be next spring. They clearly don't either. How do we handle this type of a situation?
Yeah, the state's put you in a very awkward position, and it's not very helpful in your negotiations, because from a plan's perspective, they don't want to agree to anything, and because they don't know how much they're going to get paid. They basically don't know how much money they have to work with. You know, that said, I do know that I've seen provider contracts where sometimes they do get a higher percentage than just 100% of the Medicaid payment rate. And some plans recognize that in order to include certain key providers, they're going to have to pay more than 100% of the Medicaid rate. If you're the only provider that provides the services in your community, then you may have some leverage that you may need to use and say, you know what, I'm not trying to rob you blind plan, but that rate, you know, currently is not enough and adequate for me to provide services, and I need a higher rate, and this is why.
Yeah, I mean, if we were to agree to get reimbursed 100% of Medicaid for mental health rates, we'd all be bankrupt.
Mm-hmm.
Because those rates are above what the Medicaid rates are because they're actuarially sound. So them telling me we'll pay you 100% Medicaid rates doesn't give me any reassurance that I'm going to be getting paid for what I truly need.
That's right, and part of the reason, or part of the I guess the plus side to moving to managed care is the plans are not bound to pay you just 100% of Medicaid. If that was the case, then they could just stay with the old fee-for-service system, and you wouldn't need MCOs. Part of the policy reason of moving to MCOs is that they would be able to use their judgment, and in order to attract enough providers, pay them more when needed, essentially to have them included in the network, or pay them more when they felt they needed to pay them more because the state rate wasn't covering their costs. So plans have the flexibility. Now, whether they agree to that change or not, it's going to be hard, but they do have the flexibility to pay you more than 100% of Medicaid.
So is there any recommendation you have for us as far as what language we should see in the contract around these substance abuse rates?
Well, if you're signing an MOU, then maybe you can put some protective language in that that allows you to negotiate the rates in a certain way later, or doesn't bind you to a specific rate right now. If it's the contract itself, I'm a little bit at a loss for what you do other than negotiate a percentage right now. I know that the rates haven't been finalized, but I think you just have to look at what the current rate is and what percentage you would accept of it and advocate for that.
Great, thank you.
Are there any written questions that I didn't see?
Nope, I didn't see anything come in that window.
Okay. All right, good. Well, if we're out of questions, my contact information is on the slide if anything occurs to you later. And I'll also be giving the second session, I think it's in a couple of weeks, on the actual payment terms, provisions rather, in the managed care contracts, and we can follow up with additional questions then.
Perfect. Thank you so much, Adam.
Are the slides and this presentation going to be put out?
Yes. As soon as it converts its recording, I will send out the upload and send out the link to the presentation, link to the video, as well as the slides that Adam used today.
Thank you.
Yep. Perfect. Great. Well, thank you, Adam. Thank you, everyone, for joining us. And
thanks for your attention.
We'll be in touch in a couple of weeks on the next version of this.
Sounds good. Bye-bye.